Hello, my name is Paul. Welcome to the inaugural broadcast of To Your Health. What we will do in these broadcasts, well, I guess first I should mention who I am. I'm Paul and I'm a physician. I did 10 years at the FDA in the Office of Orphan Products Development that seeks to get drugs for rare diseases to market. By the time I left, even in that niche that I was in there in rare diseases, and more so after I left, I realized there is a, to put it politely, a certain amount of incongruity between what I perceive as financially incentivized prescribing practices and what one actually finds in the medical literature, the academic research that's been done. And so what I'd like to do with these different series is to pick a topic and then just go through and see what the literature says. It's often really surprising. People are sometimes critical of the medical literature as being biased, and certainly it has certain biases. But more often than not, it's just the stuff is there and it just falls like a pebble in a pond. It never makes any difference. But I don't want to talk about myself much here or philosophize. What I want to try to do is share the stuff in the medical literature with people, which will hopefully allow them to make informed decisions which on average will better their health. Wouldn't that be great? So what we'll do for the first one, I decided, was let's look at antidepressants. And antidepressants are a huge industry. I believe it's somewhere around 1 in 10 people in the United States is on an antidepressant. It is I would guess probably about $10 billion in revenue a year. I'd have to look it up, but I mean they're clearly probably multiple blockbuster drugs, meaning more than $1 billion in revenue per year. I don't have the exact figures. Everyone knows that a lot of people take antidepressants. There is also genuine and valid concern, which is so egregious that it's difficult to be ignored or swept under the rug, that these drugs have dangerous side effects for many people. In fact, it's scandalous, in my opinion, that they are as widely prescribed, and especially to the pediatric age group as they are. As we get into things, you can see why I'm concerned about antidepressants, but I don't mainly want to talk about, oh, antidepressants are terrible, it's awful, what are we going to do? It's what are alternatives that you can make use of to help with depression, because of course depression is a terrible thing, a serious illness, and people should not have to suffer from it needlessly if there are ways to correct it that don't have these terrible adverse side effects. When I looked into things, just scanning things in the published literature, the one that I zeroed in on was not what I expected when I started. I knew enough to take a look at it. I kind of expected the and I'm not saying that these things aren't helpful, they are, but the one that was very clear-cut that I didn't know previously, zinc is very useful in depression. It may be central to many cases of depression, lowered zinc levels. Of course, things like B12 and vitamin D are useful. It didn't appear to be as consistent or as strong a relationship as one finds with zinc supplementation. So we'll talk a little bit about zinc and zinc in depression. That's the first one we're going to look at. So why don't we turn the camera around and let's get started. Yeah. Okay, let's get down to it. This is just the first thing to talk about, and this is is there a reason to look for alternatives to pharmaceutical antidepressants? And I'm certainly not expert in this area. I haven't looked at it in great depth. But this was just poking around on Google for a few minutes. And this is an article from the BMJ, the journal formerly known as the British Medical Journal. And the article is Antidepressants and Murder, Case Not Closed. So that's not very encouraging to start with. This was published August 2017. Then there was a letter in response by Professor Ghosh of the Nordic Cochrane Center. People who are in the medical field might be familiar with that Cochrane term. The professor is a member and contributor, I believe, to the Cochrane Reviews, which are rather respected meta-analyses of various health topics. Dr. Ghosh is a bit of an iconoclast. Nonetheless, he's a professor and credentialed individual in the area. So the title of his letter is Antidepressants Increase the Risk of Suicide, Violence, and Homicide at All Ages. Okay? Starts off, the FDA admitted in 2007 that SSRIs, he's talking here specifically about a widely prescribed class of antidepressants called selective serotonin reuptake inhibitors. SSRIs can cause madness at all ages, and that the drugs are very dangerous. Otherwise, daily monitoring wouldn't be needed. He's saying that the FDA said they should be monitored daily, and if they're saying that, then there's a problem. And this, I believe, is a quote from the FDA, that families should be advised to look for the emergence of such symptoms, since changes may be abrupt. Observe closely for clinically worsening suicidality. How is that an antidepressant? And unusual changes in behavior. They're saying, especially initially or times of dose increases. And this is a quote. Let me look up what that one is. Yeah, so this is from the FDA. The following symptoms: anxiety, agitation, panic attacks, insomnia, irritability, hostility, aggressiveness, impulsivity, akathisia, psychomotor restlessness, hypomania, and mania have been reported in adult and pediatric patients being treated with antidepressants, yet they're still marketed as antidepressants. Goes on, it's a fake fix, you can't monitor them all the time. And then he's also then describing the published literature related to these problems, especially suicidality and aggression. And what did he find? We showed for the first time that SSRIs, in comparison with placebo, increase aggression in children and adolescents with an odds ratio of 2.79. That would be statistically significant with that there. This is an important finding considering the many school shootings where killers were on SSRIs. This is a medical professor. In a systematic review, they showed that antidepressants double the occurrence of events that the FDA has defined as possible precursors to suicide and violence. So this isn't an antidepressant, it's something that exacerbates depression, according to this data. The number needed to treat to harm one healthy person was only 16. Goes on, increase the risk of suicide. And clinical study reports, we showed that the adverse effects that increase the risk of suicide and violence were 4 to 5 times more common with this particular SSRI than with placebo in middle-aged women with urinary incontinence. Okay, so this just goes on here. Number needed to harm was only 7. would have been quite impossible to demonstrate how dangerous duloxetine is if we had only had access to published research. In accordance with our findings, the FDA has previously announced that women who were treated with duloxetine for incontinence in the open-label extension phase of the clinical studies had 2.6 times more suicide attempts than other women of the same age. You still want to go on a pharmaceutical antidepressant. Looking at precursor events to suicide and violence is just like looking at factors for heart disease. Many say you can give it to children. Arguing that there were no more suicides in the trials, only more suicidal events. I guess that would be attempts, as if there was no relation between the two. Although we know that suicide starts with suicidal thoughts, followed by preparation and one or more attempts. The same can be said about homicide. It can no longer be doubted that antidepressants are dangerous and can cause suicide and homicide at any age. It is absurd to use drugs for depression that increase the risk of suicide and homicide. Well said. When we know that cognitive behavioral therapy can halve the risk of depression in patients who have been admitted after a suicide attempt, and when psychotherapy does not increase the risk of murder. And these are where the references that he noted are published. So we could spend hours on just the risks of antidepressants. I just brought up that one journal article and letter response by the professor to show that there is a sound grounding for believing that pharmaceutical antidepressants, in particular SSRIs, are dangerous, and ironically enough, dangerous in terms of worsening suicide, hostility, and potentially homicide. So let's continue on. Pay no attention to the man at the keyboard. I know exactly what I'm doing. Don't you try this at home. Steve Martin. Actually, I do want people to try this at home. That's part of the reason I'm doing this. So the first thing we want to do is go to PubMed, which is the repository of published medical literature. And if we go there, we can see there are all these different databases. PubMed is probably the one we want to use, but online Mendelian inheritance in men. The other one, I think it's PMC, is all articles that are freely available online, but you can search for that. They overlap about 90%, but sometimes you'll find something here that you won't there. But mainly, unless you're looking for protein clusters or something genomic, you want to go to PubMed. That's where the clinical trials are. So we're on PubMed. So what do we want to put in? We want to put in this potential alternative to conventional antidepressants, because of course depression is a serious disease, and we should look for ways to help with it. So you would type in zinc depression just like on Google. And we have 880 articles that were returned. Now what we're going to do is look at the clinical trials. We could look at the reviews, but the reviews are generally talking about the clinical trials. The clinical trials are the heart of it. So that gets us down to 42. I'm going to put down here, show additional filters. Well, before that, I don't care about a clinical trial. in mice. We want human clinical trials. Now, another reason I'm doing this is because the clinical trial is your best evidence. And by that I mean you give something to someone and you see whether it works and whether there were side effects. You can be entirely wrong about what you think the mechanism of action is, and that's happened before in the past with drugs. I'm trying to remember which, maybe even aspirin. I'd have to look it up. But the bottom line, the acid test as it is you give it to someone. Do they get better or worse? And do they get better without any other problems? So you can worry about how the thing works after we see whether there's any effect in humans. So the last thing we want to look at here, we're down to 40, so not that many, but you can go in the search fields, and I'm just going to restrict the search to the title and the abstract. The abstract is just a brief summary of the article. So that gives us 33. That's something we can deal with, and we can look through these. So we're going to go through and just look at all 33 of these articles real quickly, and might just be looking at the title, or we might pull up the abstract of the article, or we might pull up the article and really discuss it in depth. And I want to do that just so that people don't say, oh, you're cherry picking the data, you have one article that you picked from so-and-so. No, this is what showed up when you search the literature. Now there could be a few relevant ones that are missing. For instance, if it was zinc in treatment of bipolar disorder, it wouldn't show up with zinc depression if it wasn't in the title or abstract. But this gives you a pretty good idea. So when we go through these 33 articles, we'll see what we find. And not all of them will be relevant. But yeah, like here is from 2015, a current theory of why zinc has this effect. Zinc in the glutamatergic, the glutamine theory of depression. And I will probably do glutamic acid, right? Glutamate, that's what I'm looking for. Main excitatory, glutamatergic, and inhibitory GABAergic system. I don't want to get sidetracked. I may do a broadcast just looking at why zinc may act the way it does. But you can see there's different theories. Some saying it's related to absorption of precursors of serotonin. That it helps with that, tryptophan. Here's a meta-analysis where they're just looking at all the studies, and there are strengths and weaknesses to that approach. So let's just kind of, do our own meta-analysis here. But yeah, and real quickly, zinc is a necessary micronutrient for health. It is involved in hundreds of enzymatic systems. It's also an element, zinc. And people who took biochemistry might recall the zinc finger motif. So it does a lot of different things. What it's probably best known for is potentially decreasing the length of the common cold, and it is known to assist in wound healing and modulates the immune system as well. So it does a lot of things because it's involved with a lot of enzymes as what's called a cofactor. It's a necessary micronutrient for the enzyme to function properly. So it's not it's not unreasonable to think that it could have effects neurologically. So let's go through these. We'll start at the end. And what do we got? So a lot of these aren't going to be necessarily any good. Effects of zinc in hemodialysis. Zinc deficiency in anorexia nervosa. Let's look at that. So here, adolescents with anorexia nervosa, that's an eating disorder where they don't like to eat and become pathologically thin, were evaluated for evidence of zinc deficiency. They did a double-blind randomized placebo-controlled trial, and the zinc intake was low in the anorexic group. The excretion was also a third, about a little bit over a third of the placebo, or rather the control group, which, since they're not eating much, it's not that unusual. The reason I brought this one up was they supplemented them with 50 milligrams of zinc. This was followed by a decrease in the level of depression and anxiety as assessed by the Zinc depression scale. So you'll find that there's a lot of different Hamilton depression scale, Zinc depression scale, etc. And they're just questionnaires that they've tried to validate. When someone's doing bad on this questionnaire, then clinically they're pretty depressed, and they give them how blue are you? Is this the most blue you've ever felt? I don't know exactly the questions on the scale, but it's to assess how depressed they are. So the Zinc depression scale, and then for the anxiety, the state trait anxiety inventory. So they note that there was a decrease in the level of depression and anxiety in these people with anorexia nervosa when they were given 50 milligrams of elemental zinc per day. That's not a lot, relatively speaking. I think I just picked up some zinc the other day, and one tablet is 50 milligrams. I can try and look up what the RDA is, but I think it's in that ballpark. And this is also important. They said the P is less than 0.05. The P value is less than 0.05. I don't want to do a whole course on statistics here, but the way you would read that is that there is a less than 5% chance that this decrease in the level of depression showed up just by random chance. So in other words, you were dealing a deck of cards and you got 3 aces in a row. That's not very likely. It can happen, but they're saying that when they applied the correct statistical analysis, assuming there's no bias and they're independent events, it's a whole PhD, statistics, of course, that assuming all that, the way you would read this is that there's a less than 5% chance, a less than 0.05 chance that this decrease in the level of depression and the decrease in the level of anxiety was just a random thing that just happened to show up. Okay, I said I wanted to keep these to like 20 minutes each. I think we're already kind of going over that. But, we're only to 1997 here, so much of what is known has been determined rather recently. But here's sort of a first kind of shot across the bow. Oh, I already had it up here. Lower zinc in major depression is a sensitive marker of treatment resistance and of the immune inflammatory response in that illness. So we're just looking at the abstract so far, and I'm also, if people can't get the full text themselves, I'm not going to bring up the article because, again, this is something I want people to do themselves. I live 2 miles away from National Library of Medicine, so if in no other way I can get pretty much any article that I want. But I want this to be stuff that people can see for themselves, not, this is some obscure article that you can't ever get. So that's why this doesn't have a full text article, the full text of the article, so we'll just talk about the abstract. And again, we're back at 97, and so this is just coming to light, the effects of zinc. And they were looking to examine about zinc and copper in people that weren't getting better from their depression. And what they found was a significant inverse correlation between zinc, serum zinc levels, how much zinc was in the blood, and the stage of the depression. So in other words, since it's an inverse relationship, if they have higher zinc levels, they have less depression. If they have lower zinc levels, they have a higher stage of depression. There were no significant effects of antidepressant on the serum zinc. They also note here there was a correlation between serum zinc levels and cluster domain 4, CD4, and CD8. It's probably kind of in the popular culture because of AIDS. CD4 cells and CD8 cells and T cell ratio. So zinc is also having an effect on the immune system. But what they're pointing out here is that lower zinc is a marker of treatment-resistant major depression, so that people with low zinc levels are more likely to have a difficult-to-treat major depression. Okay, I think that's enough for this first part. In the second part, we're going to plow through the rest of these studies, and you don't want to miss that. There's going to be, here's the first one where they're actually giving zinc and seeing what it does in unipolar depression. This is a placebo-controlled study. Zinc in the treatment of dysgeusia. Where else are you going to find that but on this channel? Dysgeusia is if you lose your sense of taste. But that one's actually interesting too, because they got better, their depression got better, and their taste came back. You know, you can say, well, it's a they're not depressed because they can taste food again. But in any event, there's a lot more. That's just the first page, and then we got another page. But I don't want to make each of these like 3 hours long, and we're probably going to be coming up on a half hour here pretty soon. So I'll stop here. If you like this, by all means subscribe to the channel, and you can go to my Twitter feed, TL Health on Twitter. And till next time, here's to your health. Thank you.